About 50% of the decline in death rates from heart disease in the last 5 decades actually has been attributed to reduction in smoking purely. And that happened because of taxation of cigarettes and improving the environment. In 2011, in one of the premier cardiology journals, the editor-in-chief of that journal, William Robert, he wrote an article, "It's the Cholesterol Stupid." And he said, in quotes, "You can be an obese, sedentary, diabetic smoker, but as long as your cholesterol is low enough, you will not develop heart disease."
Are there any scenarios where you might consider prescribing a statin?
So with statins, even though I said lowering cholesterol is essentially a waste of time, statins have other benefits independent of lowering cholesterol.
Going on to side effects, I think there's new research saying that it can cause issues with mitochondria. On today's episode of the LiveMore Podcast, where we focus on peak human performance, health optimization, and longevity, I had the pleasure of interviewing consultant cardiologist Dr Aseem Malhotra. Aseem is most well known for being a public health advocate challenging big pharma and big food, along with the narrative that cholesterol is the main driving factor for causing atherosclerosis or heart disease. I hope you find this conversation as useful and valuable as I did. If you did, please share it with a friend or family member, and I'd be grateful if you can subscribe to this channel. Thank you so much. Welcome to the show, Dr. Aseem Malhotra. I've been a long time admirer of your work around public health and specifically around the oversimplification of cholesterol being the main driver of heart disease. I think you've brought to our attention that there are other factors that we need to take into consideration. Heart disease is something that's incredibly personal to me because my dad suffered a heart attack back in 2007, had some stents put in, and then subsequently had a triple bypass in 2015. Thankfully, he's still alive and well with us today, practicing as a GP. And he spent decades working in the NHS as an A&E consultant. And if there's something that he's taught me that stuck by me, it's that prevention is always better than cure or treatment. And I think this subject isn't just academic, but also personal to you based on listening to your Joe Rogan podcast and what you said on Diary of a CEO about the impact it had on your dad. And I believe your mum and your older brother was affected in some shape or form. So with that said, I'd love for you to introduce yourself for those who aren't familiar with your work. And why is it that despite advances in medication and in medicine, that heart disease is still the world's #1 killer worldwide?
Rob, thanks for having me. Lovely to be here. Nice studio you've got as well. Where do we start? So I think there's a few really important points that you've mentioned already, and certainly in relation to what your father's saying, prevention is better than cure. He's absolutely right. When you look at the contribution of modern medicine to increasing life expectancy, in the last 200 years, life expectancy has gone up in 1850 from an average of 40 years to approximately 80 years now in the Western world. Of that 40-year increase, and this is something that is a misconception out there, for lots of reasons why the misconception is there, including ideology and commercial interests as well within medicine, is that probably around 3 to 5 years, depending on what studies you look at, is attributed to modern medicine in terms of increase out of 40 years. Most of what determines your health is to do with your, the conditions in which you were born, grow, live, work, and age. So having, early child development, basic needs being met, good housing, education, having a job that allows you to lead a healthy life. These are the real factors that contribute to your life expectancy. And of course, over those last 200 years, if you look at what has contributed to that increase, it's been things like mainly public health interventions, safe drinking water, seatbelts in cars, smoke-free buildings. And with smoking, for example, talking about heart disease, about 50% of the decline in death rates from heart disease in the last 5 decades actually has been attributed to reduction in smoking, purely. And that happened not because of just education. Education played a role, but more importantly, it was taxation of cigarettes and improving the smoking, in the environment, basically public smoking bans. So it's important just to get that perspective to start with, because then when one talks about modern medicine and say heart disease, one can then appreciate that whatever we're talking about in terms of so-called advances in medicine are likely to have only so far very incremental benefits. And when one looks at the way that we've approached heart disease in the last several decades, there is a mindset globally, I would say, an indoctrination amongst doctors, cardiologists, lipid doctors, specialists, is that the primary driver has been so-called high cholesterol. And to give you an example of that level of indoctrination, in 2011, in one of the premier cardiology journals in the US, the editor-in-chief of that journal, his name is William Roberts, if I remember it correctly, he wrote an article entitled, "It's the Cholesterol Stupid." And he said, in quotes, "You can be an obese, sedentary, diabetic smoker, but as long as your cholesterol is low enough, you will not develop heart disease."
That's ridiculous.
It sounds ridiculous, doesn't it? It sounds a bit too, it doesn't sound very wild. So the question is that true? And I've spent the last 15 years of my career, I would say best part of 15 years, where I've been going in depth looking into the cholesterol hypothesis and trying to keep no stone unturned, and published in medical journals on this. My third book, called Statin Free Life, covers it in a lot of detail. And essentially, that isn't true. When people have looked at this independently, two cardiologists and myself actually published a paper in 2021 in the journal BMJ Evidence-Based Medicine. And we looked at 35 randomized controlled trials done by the drug industry, which have huge caveats already because they are based upon data that is controlled by them and never independently verified. So even looking at that published data, which is only probably a half truth, and there to exaggerate the benefit of the pills. And we looked at statin drugs, we look at the new injectable drugs for low cholesterol, PCK9 inhibitors.
Yeah.
We looked at the another drug called ezetrol or ezetimibe.
Yep.
And we asked this question, is this true from those trials? When you put them all together and you look at the cholesterol lowering and their correlation with reduction in heart attacks, strokes, death, whatever, there was no correlation. There was no clear correlation. So listen, we could be wrong. But it at least allows people to question that conventional hypothesis. And we are people looking at it from a perspective where we don't have any financial interests in the drug industry. The people who've been involved in those guidelines and the people who've come out with that dogma, unfortunately, are very heavily financially conflicted. But I don't think it's just that. I think it's ideology. I think one of the problems we face, one of the challenges we have in modern medicine is the fact that there isn't enough good science. And what I mean by that culturally is that scientists who are ready and willing and open to question their own beliefs and hypotheses, because that's what a good scientist does. And that's a real problem. And we've gone from good open science being all about accepting potential uncertainty, so you're open to things changing, to it becoming almost an ideology, a mechanistic ideology. And that is defined as a naive belief in the measurability of reality and the use and excessive use of data and statistics. So this then comes back to the whole issue about medicine, a false perception that medicine is an exact science when it's not even close. Even science is never completely precise. There's so many uncertainties with what you consider to be the pure sciences, whether it's physics, chemistry, astrophysics, for example. There's still lots of uncertainties there. That isn't precise. Medicine is even less so. To give you perspective on that, the father of the evidence-based medicine movement, David Sackett, said, and this is proven to be true, 50% of what you learn in medical school will turn out to be either outdated or dead wrong within 5 years of your graduation. The trouble is nobody can tell you which half.
That's shocking.
So you have to learn on your own. But that's, that's great in a way. Like it just gives, it allows greater diversity of thought and thinking and open-mindedness rather than being rigid. And that rigidity has got us to where we are right now, which is the fact we've got an increasing burden of chronic disease. Life expectancy in the UK has stalled since 2010. It may even be going down. It's certainly decreased in the United States. And the United States is a perfect example of what happens when you completely commercialize healthcare. The highest healthcare expenditure in the Western world with the worst health outcomes. So when it comes to medicine, certainly, the greater money involved, the lower the quality. Costs go up, quality goes down. That's kind of counterintuitive to people living in a materialistic world where they think if you pay for something, more money for something, you get better quality. In medicine, it's the opposite. Right? John Ioannidis, who is the Stephen Hawking of medicine, in my view, professor of medicine at Stanford, most cited medical researcher in the world. He wrote a paper in 2006, which has become the most cited downloaded paper in medical history, which is called Why Most Published Research Findings Are False. And he said the greater the greater the financial or other interests in a given field, prejudices, the less likely the research findings are to be true. And statins are certainly cholesterol lowering. Statins are off patent now, but it still obviously generates a lot of money from the fear of cholesterol. This is a $1 trillion industry. So these are the challenges we have, Rob, in getting to a greater truth. Is a indoctrination, groupthink, human nature, or the negative aspects of human nature, and then it's all fueled by very powerful commercial interests that have become a tyranny. Because their power is so huge, they exert it in a way to sustain that power, that financial power, by a business model that is basically fraud, deliberate deception in order to make money.
Understood. Are there any scenarios where you might consider prescribing a statin?
So I think the question should be, are patients being fully informed? And then are you supporting the decision of the patient? So with statins, even though I said lowering cholesterol is essentially a waste of time, statins have other benefits independent of lowering cholesterol.
Anti-inflammatory
and anti-clotting. So their likely benefit, which I'll tell you about, is through that mechanism, not through lowering cholesterol. And when one looks at the gold standard of informed consent, you should communicate benefits to patients when you have that information available in terms of absolute risk reduction. So what is the benefit for you, likely benefit for you as an individual, taking a statin over a 5-year period, for example? And that's based upon drug industry trials, again, which again is selected, right?
So you made reference to 1 in 100, I think.
Yeah, it's
for
likely
primary prevention.
It's likely a likely exaggerated benefit. But yes, in low risk populations, or even high risk primary prevention, so these are people that have not suffered a heart attack or have not been diagnosed with a severe blockage, okay, in their arteries. The benefit is, again, you're right, 1 in 100 in preventing a non-fatal heart attack, a non-disabling stroke, but without prolonging life. So if this conversation is happening, rather than say, is there a situation to prescribe a statin? If I told the patient that information, they said, doctor, I like the statin, I said, of course I'll prescribe it for them. If you take the high-risk groups, Rob, which I think you're coming on to next, which is people who've had a heart attack, that benefit increases to 1 in 39.
1 in 39, right.
And 1 in 83 for what we call mortality benefit over a 5-year period.
But what happens if you extrapolate that risk over a longer period of time? So we're just looking at 5 years. What about if you look at that over decades? So let's say 20, 30, 40 years. You can't assume that relationship is linear, because
so you can't. It might stop at 5 years. We don't know, actually, the answer to that. We don't know the answer. So we can only be precise about 5 years. But if we were to say it was in 5-year blocks and it was a benefit that was linear over 5 years, for example, the median increase in life expectancy, looking at the data differently over a 5-year period in the high-risk groups, is just over 4 days. You could then say, well, fine, over 20 years, it'll be, 4 times 4, 16 and a bit days, whatever, almost 17 days. So the information, patients ask that question, that comes under uncertainties. We don't know, but we usually start with the 5-year plan in terms of what we can be more precise about, because that's how long the randomized controlled trials ran for. But then you've got to add in other things, like these are in people that didn't get side effects because they were taken out of the trial. What are the side effects? Are there any alternatives? All of these come into the conversation.
Going on to side effects, I think some are well documented. So, for example, muscle pain, I think, is one of them. I think there's new research saying that it can cause issues with mitochondria as well. And I also think you mentioned that cholesterol is important. Obviously, it's necessary for survival. There's also some evidence to say that statins might actually increase insulin resistance as well.
Yeah.
So I'd be interested to hear what you say about that. How do you take those kind of factors and side effects into consideration?
Yeah, so the side effects issue is a very controversial area, and it depends what research you look at. In my clinical experience and looking at the data overall, I would say at some point in one's lifetime, 20 to 50% of patients will experience or at least report what seem to be side effects from statins. The good news in most cases, it's reversible within a few weeks of stopping them. But the most common side effect that comes up is muscle pain or fatigue, which fits with the mechanism of it causing mitochondrial dysfunction. I don't think it's fully understood yet what the mechanism of insulin resistance is, but either way, it is shown with good quality data that it does cause type 2 diabetes in between 1 in 100 and 1 in 50 people. I think that, again, that is probably reversible, because I've had patients myself that come with their glucose being up, HbA1c, whatever, and they stop the statin, it gets better. So I think that's good. And then, of course, other common complaints are things like stomach upset, brain fog, erectile dysfunction. So there's quite a wide range of side effects. One of the problems is, or one of the issues is, which I've highlighted, is because doctors were originally, thought to believe the side effects were quite rare, less than 1% of people getting anything of a quality of life limiting, then they'll often miss a diagnosis, and they'll send someone for a test, for example. I had this patient, I remember I wrote about this years ago. In fact, the first article I wrote in the mainstream about my concern on statins, interesting, was a Mail on Sunday in 2012. And the title of the article was Suffering on Statins. In fact, it was before 2012, I think. Hold on, let me try and think. No, it was 2012 was actually when it was, yeah. Right. Suffering on statins, stop taking them now. And it was reference to a patient that came in who had had a heart stent, probably like your dad, and was put on statins and had come into, a few months later and complaining of quite severe chest pain. The chest pain didn't sound typical of cardiac pain, though, but it was like, you still worry, the stent blocked off again, or was there a problem? So he went back for another angiogram, had the angiogram completely normal. And he said, well, what about my chest pain? Said, okay, probably reflux or something, right? Heartburn. Gave him some pills for that. Comes back to the clinic, still complaining, now miserable. Pain's traveled to other parts of his body. Wife said he's depressed. I don't know at the time, for some reason I thought it could be the statin. I stopped it. Gave him an appointment for 3-month follow-up within the NHS. He came uninvited about 10 days later to the clinic, turned up, elated, saying for the first time in months, my pain's disappeared after stopping the statin. He couldn't believe it. Everything got better. But this is a funny thing. He went back to his GP, and the GP said, you must never stop your statin, otherwise you could die. And of course, that shows a lack of understanding. I mean, this is something I talk about. We've got a pandemic of misinformed doctors and misinformed and unwittingly harmed patients. And one of the factors behind that, Rob, is an inability of doctors to comprehend and communicate health statistics, because we're not conditioned and trained that way. It's not complicated maths. It's very, very simple. Yeah. But we're not conditioned to practice medicine in that way. And I have campaigned on this issue with the medical Royal Colleges in the UK in 2015, 10 years ago, to say that we need to change the culture, we need to change medical training. It hasn't been incorporated yet. And one of the reasons is, I think, part of the reason is, when patients are fully informed, they choose less treatments. And that's not good for the interests of the pharmaceutical industry, who are only interested in making money, by the way. Remember that. That's very important to people understand.
I think you made the point that I think the third leading cause of death is overprescription of
One estimate suggests the third. I mean, if it's not the third, it'll be up there. But the third leading cause of death after heart disease and cancer globally is prescribed medications.
That's shocking.
Prescribes. Yeah, it's an absolute scandal. It's an absolute scandal, Rob, what we're talking about here. And I've dedicated my life to try and help solve that problem.
What about in the context of metabolic health? Because we have very well-known people in the longevity space. So, for example, Peter Attia and Thomas Dayspring saying that LDL is causal, ApoB is causal. You need to minimize it, even in the context of good metabolic health, by slashing it down below 60 milligrams per deciliter. Yeah, what do you have to say around that?
Well, it's not bad to say. I mean, we've done our analyses. They can look at our analyses and they can ask, the question is where they're getting their information from and what are the biases there. I don't know Peter Attia or Dayspring. I would ask, first and foremost, have they got any financial conflicts of interest? Has Peter Attia ever received money from the pharmaceutical industry at all? Done any consultation fees for? I don't know. I'm just saying. I'm asking the question.
Yeah.
But if not, great. Let's have a debate and discussion here. But there are so many layers to this, not just one thing. I was also involved in a systematic review in 2016, published in the BMJ Open, which revealed that if you're over 60, the higher LDL cholesterol, the longer you live, no association with heart disease. We've done studies on familial hyperlipidemia. There are other brilliant scientists I've worked with who have done most of the research in this area. David Diamond is one, who's a neuroscientist PhD, and Ofe Ravskov as well. We published a paper where we found in people with familial hyperlipidemia, where they have, in fact, 1 in 250 people.
Familial hypercholesteremia, same thing, right?
They have very high LDL levels. And what we found was, if you start from a bird's eye view, 70% of women and 50% of men, untreated, will not develop premature heart disease. Okay?
Are those people metabolically healthy?
With FH. Well, let me finish.
Okay.
So those people will not. And then you look at, what are the differences in those people? In the ones that develop heart disease and the ones that don't. And actually, it came down to LDL, no difference. So LDL is likely not a contributor, not a factor here. It was clotting factors and it was metabolic health. So if their insulin levels were low, fasting insulin was low, and their waist circumference was low, in other words, they had optimal metabolic health, their relative risk of having heart disease was only slightly higher than someone else who was a healthy person in the population. So again, it's another nail in the coffin for the LDL hypothesis here. One of the so I think that it's more nuanced.
Right.
You asked earlier about looking at Q-risk calculators.
Yeah.
Okay.
Absolutely.
And within Q-risk calculators, LDL isn't in there. Q-risk calculators are used basically by doctors to calculate your risk of a heart attack or stroke in the next 10 years.
Doesn't even take into account your triglycerides, for instance.
No, it doesn't. But it takes into account total cholesterol and HDL. And that in some ways is a surrogate for triglycerides. It's not ideal. So your total cholesterol over HDL ratio is important. When you look at heart disease progression and development, the data suggests triglyceride to HDL ratio is more important. And that's what I look into. One of the reasons, Rob, why that hasn't been pushed is the drug trials that were done, which altered HDL and triglycerides, didn't show any significant benefit. So they kind of pushed that out of the way. Whereas with LDL, although it was statins, other mechanism, my personal view is it's likely that it isn't so much the triglycerides and HDL, more that they are a marker of insulin resistance. And insulin resistance is the primary driver because chronically raised insulin does damage coronary arteries. So once you collect insulin resistance, the markers of insulin resistance are triglycerides and HDL. And it's one marker of your insulin resistance being optimal.
Is insulin resistance the mechanism for causing inflammation? And is that another factor?
It can be. I think inflammation can work in separate ways to insulin resistance. I've seen people who are chronically inflamed who have perfect metabolic health through some other mechanism, whether it's chronic stress, whether it's some toxin they're ingesting, or some kind of food, whatever. So I think you have to look at them as linked, maybe overlapping, but also separate.
Interesting. If you look at the pyramid of health, so I consider that to be diet, sleep, exercise. In what order would you prioritize them?
Well, I think if you look globally, Lancet Global Burden of Disease reports tells us that poor diet is responsible for more disease and death than physical inactivity, smoking and alcohol combined. So I think for me, it's poor diet by far. However, if one was to look at the drivers of what gets you to the poor diet, I think it's psychosocial primarily, And that means that stress is probably a big factor, even starting in childhood. If you are a child, for example, that is a victim of severe psychological or sexual or emotional abuse, that can knock off 10 to 20 years off your life expectancy. And the factors that play in there are stress independently, having a negative impact on your body, your health, your heart, promoting clotting factors, aging quickly, chronic inflammation, but also the behaviors that then happen because of the fact that you're subject to severe stress, lack of safety and security, for example, will then drive you to the addictions of ultra-processed food, which then has an additive effect. So I think for an individual, and even for populations, is that we need to think about, we have to come back to, I think, the way our culture, the way we think, and the way we as I said earlier, the way we are, we call this the social determinants of health, if you like. Michael Marmot is a guru on that. And I said that, what determines your health more than anything else are the conditions and the environments in which you are, born, grow, live, work, and age.
Interesting. Mental health is obviously a big issue at the moment. It's a mental health epidemic.
Yeah, this is what I'm talking about.
People are a lot more stressed.
Yes.
And surely that must be influencing, the
100%.
The stats around heart disease
100%.
Well.
And my friend and colleague Matthias Desmet actually sums it up very well in his book, The Psychology of Totalitarianism, which people must read. And he talks about also what makes us vulnerable to false narratives as well. But it comes back to, first and foremost is social isolation. Social isolation brings meaninglessness, because what gives us greatest meaning in life, if you look through history, is what we do for the other.
Absolutely.
It's what we give back.
Purpose, ikigai, they call it.
Absolutely. Interconnection, understanding we're interconnected, having some meaning and purpose in life. But what's happened in society, we've become increasingly disconnected from seeing that in many ways and being more individualistic. So you get social isolation. Social isolation brings meaninglessness. Meaninglessness gives anxiety.
Absolutely.
Okay.
Social media has contributed to that
100%.
Immensely over the last decade.
And then there's also a kind of a brewing aggression and frustration with that anxiety, which means that we are vulnerable to finding a false enemy that is created by us by potentially government or authoritarian figures. And we saw that play out. If you see if you look back now and think about how did we handle and approach the COVID pandemic, it was all down this line of, a mass hypnosis, if you like. Doesn't mean that COVID didn't exist or COVID wasn't a problem. It was the way that we approached it was, exacerbated the problems, didn't make them better.
Absolutely. I think you made a point around, I think your dad suffered from a heart attack. And
he didn't actually have a heart attack.
Right.
No, he didn't have a heart attack. So just to be technically clear on this, a heart attack is when you have damage to the heart muscle, cell death, because of an acute blockage in an artery that completely destroys, stops the blood flow getting through. He had a cardiac arrest, which basically we all ultimately have a cardiac arrest before we die. It's when the heart stops beating. And the cause of the cardiac arrest ultimately was because he had coronary artery disease and probably reduced blood supply, not enough to cause a heart attack per se, and a rhythm disturbance that then caused a cardiac arrest. But yes, I mean, it was similar to having a heart attack, but it was a cardiac arrest that was related to coronary artery disease, which was likely, in my view, driven, or a huge factor that played into that was the COVID vaccines.
Understood.
Yeah. Through a chronic inflammatory process. And heart disease, I wrote a paper in 2017 with two cardiologists, both editors of medical journals and British Journal of Sports Medicine, which was called Saturated Fat Does Not Clog the Arteries. Coronary artery disease is a chronic inflammatory condition which can be effectively managed with lifestyle changes. And in that, I make the point that heart disease, actually the narrative on heart disease should change to really a chronic inflammatory condition that is influenced by insulin resistance and metabolic risk factors.
What makes you think the vaccine may have caused the issue with your dad? Well,
I think it's a number of different areas. One is I knew his lifestyle. I knew that he had a calcium score done a few years earlier. There was clearly something had caused a rapid progression, which I couldn't pinpoint at the time. And then later on, the research emerged showing that within 2 months, for example, one bit of research published by a very well-respected cardiothoracic surgeon in the United States called Stephen Gundry in the journal Circulation showed that in his patients and middle-aged people, within 8 weeks of having 2 mRNA jabs, it increased their baseline risk of a heart attack from 11% to 25% just in 8 weeks. Which is extraordinary.
That is shocking.
And that was only one mechanism. Of course, you don't rely on one study. And it was through inflammatory markers, right? He showed that, which are correlated with cardiovascular risk. And then, this was replicated with real world data and the fact that I also was contacted by a whistleblower at a prestigious institution in England who told me that they had accidentally found through heart imaging modalities that vaccinated people were showing inflammation in the coronary arteries, which was not there in the unvaccinated. So there's lots of other research that's come out kind of supporting that. So for me, that was almost certainly, and he had this cardiac arrest 6 months after having the COVID vaccine.
Right.
So this is not necessarily something that happens immediately. It can happen immediately, but in many people I've also been seeing other patients where you look, I train in interventional cardiology, so heart stents, coronary angiograms is my sort of bread and butter. And I've seen patients where everything has been stable. They've had an angiogram and a stent. One of their other arteries has some mild blockage. 9 months later, they present with further chest pains. You do an angiogram again. This very minor blockage is suddenly 90%, which doesn't usually happen in 9 months. That's what we call very rapid progression. And the only thing that's changed in those 9 month periods is two doses of the COVID vaccine or 3. So there are lots of bits of evidence which suggest it's inflammatory.
So going on to screening, we have, for example, CAC, which gives you a score of calcified plaque, I believe.
Yes.
So is that what you had done with your dad like a few years before?
Yeah.
Interesting.
Yeah.
But doesn't that just pick up calcified plaque? Is there an argument to say that if you'd done a CTA, that it might have picked up soft plaque as well, which is more prone to rupture?
So that's theoretical to some degree, but actually coronary calcium is also a surrogate for soft plaque. So the higher the score, it's picking up calcification within. It's not even calcified plaques. It's just calcium deposits within plaque. Some of them are more calcified than others, and some of them have no calcium at all. But it's a surrogate for soft plaque as well, and it's the most predictive of all tests of heart attack anyway. Over the next, 10 years. Yeah,
I actually got one done over the summer because I'm perfectly metabolically healthy. I've just got high Lp(a). And obviously, because my dad had a heart attack, I was a little bit concerned. But thankfully, my score came back as 0.
Okay. And how old are you, Rob?
I'm 43.
Okay. You didn't want to have a CT coronary angiogram?
I haven't had one done yet.
No, you don't need it, to be honest. If your metabolic health is fine, your calcium score is 0, I wouldn't worry.
Yeah. So
did you look at what likely caused your dad's premature heart disease? Was his lifestyle different?
To be honest, I'm not exactly sure what caused it, but I think it might have even been family history. It might have been stress. I'm not exactly sure what the underlying cause was.
Yeah. But was his metabolic health perfect when he had his heart attack? I suspect
that's a great question.
Don't know.
I don't.
Sorry, on his stent.
Perhaps it might have not been because I know he wasn't exercising as much, and I know my mum at the time was working out a lot and exercising, and then I think he made a switch. And
I don't think exercise plays a great role, to be honest. I think there's a big myth out there. A lot of that has been pushed by McDonald's and Coca-Cola.
Right.
And the reason I say that is I've studied the areas of the blue zones. I've been to, my first book, Pioppi Diet, was based upon this southern Italian village, which is the home of the Mediterranean diet. Poor community, but life expectancy above 90. None of these guys were in the gym. None of them were ripped. None of them. They were just out walking in the fields. They're just walking. Just moving, just not being sedentary. I think being sedentary is a problem, right?
Absolutely.
I think if you're sitting on the couch all day,
they say sitting is the new smoking,
which is like a stereotype. I don't think there's many people actually just sit on the couch all day. Really, I don't think there's many people that exist like that out there. I think there's a bit of a stereotype. Yeah, it's a bit of a, but I think that if you look at longevity, I think in general, elite athletes don't live any longer than golfers or cricketers. So just doing something is important. But I think people obsessing, and in fact, actually, what's interesting is I got a letter once about a patient from a very reputed sports cardiologist in London, one of the most well-known. And I was interested, when I read his letter, I never forget him writing this. He said 11% of elite athletes by 50 will have calcium scores over 1,000.
Shocking.
So I've had patients where they are ripped, they are running 10 miles a day, and in their 50s have got severe coronary artery disease. Everything else is fine. And I think that overtraining can cause heart disease.
It can also cause AFib, right? Atrial fibrillation.
Possibly, yeah. I think there's a big issue there, especially if you're stressed and not sleeping well. I think overtraining is very, very bad for you. There's no sort of dose response. I think, after a certain point, then you plateau. And if you do more, it can potentially be harmful.
It's interesting because a lot of longevity experts have been pointing to research around VO2 max. And so, yes, I can understand how moderate exercise is more accessible to the general population. But do you think the evidence points to some level of intense activity being beneficial?
I think it's about balance. I think, yes, to some degree, but I would not recommend people do high-intensity interval training. Certainly with the people I see, that are super stressed and the people at risk of heart disease, I tell them no more than once a week. They've hit.
Right. Because there's things, for example, like the Norwegian 4x4, which has shown evidence for improving things like VO2 max.
Yeah, sure. That's fine, Rob. But then we're looking at a biomarker. We have to translate that into actually what does that mean in the end? You know, there's I can't remember, there was two amazing sports scientists saying that, you know, your fitness can improve, but your health can decline.
Interesting.
VO2 max doesn't necessarily mean you're healthiest. You have to look at the whole picture.
Absolutely. I think you have to
So think about that. You can have an amazing VO2 max, but be in crappy health.
Absolutely. That makes sense.
You know?
That does make sense. So in terms of other factors that we need to take into consideration other than metabolic health, stress is obviously one of those big factors.
I think it's the biggest, one of the biggest. Chronic stress as a risk factor for heart disease is now equivalent to smoking 20 cigarettes a day. And most people are not dealing with it, and we're more stressed than we've been certainly in modern history. I
want to bring a real life scenario to you, because one of my closest friends, he's got metabolic syndrome, very high triglycerides, like around 4.4, low HDL, like 0.93.
Yeah.
He's taking SSRIs as well, around my age as well. So his Q-risk score, I think, came back as around 10.5%. So fairly moderate. If this was your friend, your very close friends, like practically like a brother, what would you be advising them in terms of like improving their kind of health outcomes?
Well, it's difficult. Obviously, I need to talk to that individual and get the full picture here.
Yeah.
From what you told me, I mean, the most important and the quickest way to improve metabolic health is obviously dietary change. So we see that happening within a few weeks of going on a low-carb diet, ideally a low-carb Mediterranean, only because I feel that there is some evidence of benefits from anti-inflammatory foods, extra virgin olive oil, omega-3s from oily fish, nuts and seeds, non-starchy vegetables, low-sugar fruits, that kind of thing, eliminating all starch. You'd probably, you know, with this particular person, I would usually say, let's do this for 6 weeks, break the addiction from sugar and starch, and simultaneously deal with the stress side as well. I suspect there's a stress element there. So that would be maybe, you know, referring to someone that can teach him breath work, trying to understand any other factors in his life that are contributing. So that would be the basis that I would start. And you would see, you know, if you go on a low-carb or keto diet, the benefits usually peak at 3 months, but you'll see a big benefit at 6 weeks in the majority of people. So I would then repeat the triglycerides and HDL in 6 weeks and see where we're at.
Interesting. You also mentioned something around Raj Yoga meditation. Do you think that could be beneficial? Is that something that you practice yourself?
Raj Yoga meditation is prescribed and practiced by a cardiologist in India called Satish Gupta, who did work in the early 2000s and revealed that heart disease blockages could be reversed from a lifestyle change. But the only independent factor for reversing heart disease was 40 minutes of Raj Yoga meditation a day. It wasn't just a breathwork meditation exercise. It was a change of mindset. It's getting the family in, understanding what was driving anger, and, you know, and was
nourishing relationships and that kind of thing.
Absolutely.
As well.
So, absolutely really important. Yeah.
Fascinating.
I mean, I personally, I follow Buddhism as best as I can, because that resonates with me. It's science of the mind. But also, every day when I wake up in the morning, I do probably, I would say, anything from 25 to 30 minutes of breath work first thing in the morning. I do that every day.
What about if an individual is having troubles with compliance around diet? Do you think there's a role of GLP-1s, like, for example, like Manjaro, in terms of trying to improve metabolic health outcomes or not?
Never say there's never a role, but I don't think it's something that should be primarily used. In an interview with the Telegraph newspaper, I said, because of the scandal, the catastrophic public health catastrophe from the COVID vaccine, based upon non-transparent data, we should start a Just Say No campaign, in the sense that we should not accept any new drug that comes from the drug industry until the data is independently analyzed. And these injectable weight loss drugs also cause so many side effects that are coming out, more and more of them. You lose muscle mass.
Lots of lean muscle mass.
There's lots of ways to lose weight, including getting cancer. Right? So it's about, is this a healthy way to lose weight? In my view, no. I'm open-minded if some new data emerges, but we also know there's lots of side effects. So no, it wouldn't be on my list at all, to be honest.
What about strength training in terms of improving metabolic health outcomes in conjunction with that, if people are willing to adopt strength training?
Well, I just don't know. I don't think so. I would avoid it altogether, to be honest, Rob.
Okay.
I wouldn't give it to my worst enemy.
Understood.
As Ian Botham said years ago, when there was a controversy about England cricket team going to Pakistan, he said, I wouldn't send my mother-in-law there,
Yeah.
I hope that I would have a better relationship with my mother-in-law, but I wouldn't give it to my worst enemy. So, yeah, I think that you focus on the lifestyle primarily.
We were both.
And if people are going to take it, they need to be fully informed on the limitations. I always tell patients, what information I'm about to give you is not independently verified. It comes from drug industry-sponsored trials. Drug industry are there to make money. They are pathologically self-interested. They've been diagnosed as psychopathic. I mean, I give them all that information. And patients want that. They love to hear this stuff. And say, and then would you like to take the pill? Because that comes under element of what we call uncertainties. And I would say that same with the injectables. In relation to the lifestyle stuff as well, I think it's fair to say, listen, this is going to improve your metabolic health markers. I don't think it's going to give you any side effects. Your quality of life is going to improve. Have we got long-term data on this intervention improving your heart attack, stroke, death? No, we don't have that hard quality data either. But there is an intuitive intelligence that comes in because also it's a lifestyle and because it's free of side effects and improves quality of life. People are going to more likely want to choose that.
Fantastic. What about the role of supplements like vitamin D, omega-3s?
Yeah, I think there definitely is a role for supplements. Certainly, I wrote my second book, was called 21 Day Immunity Plan, in relation to my work around highlighting the risks of COVID with poor metabolic health. And I was asked to advise Matt Hancock at the time. So I looked into that in a lot of depth. And certainly, I'm open-minded, but a lot of, again, we've got to be wary of a supplement industry which acts like Big Pharma as well. They're not as big as Big Pharma, but they're there to sell supplements.
Absolutely.
I think the key supplements, certainly vitamin D has an important role to play for sure, because most people aren't getting enough sunlight. And, I think it's important for the immune system. It's important for preventing cardiovascular disease. So vitamin D definitely has a role to play, I think, for most people, certainly during the winter months in this country. And vitamin C, for example, I think for immune system. I think for stress, I've personally found, in addition to the breath work, supplements like magnesium can be quite helpful as well, magnesium glycinate. There are definitely some supplements that I think you've got what's right for you. I don't think you should be taking, 50 different supplements a day. Maybe some people are.
Yeah.
I don't necessarily think that's a good idea, but you've got to understand why you're taking it and what it's doing for you and what could be the harms. We also don't know, like we do with pharmacotherapy, how the supplements interact. That may be something we're not aware of and will come out.
That's a good point. Omega-3s? Do you take
Yeah,
omega-3s?
absolutely. I think if you can get it from oily fish, ideally, that'd be better. There's probably something with the synergy of the omega-3 and the oily fish with other components in the food and the olive oil, for example, that has a better effect. If you can't get it from oily fish, then, I would cod liver oil. I think it's great.
Got it. What about, I think a lot of people are doing like vaping instead of smoking. Do you think that
Terrible.
is
Terrible.
It's awful, isn't it?
Absolutely terrible. They cause heart attacks. Vaping causes heart attacks. Good evidence for that now. I think almost as bad as smoking.
That's important because my friend is a chronic vapor.
I know. So it sounds like he's got a lot of stress and he's got addictions, and they need to hit them hard all at the same time. But he needs to help his mental health as well. So the stress reduction combined with a dietary change would be the approach I would use for him. Very intensive stress reduction combined with dietary change will help him get through the addiction process, and he'll feel better, and then he'll be more motivated to stick to it. Got
it. We were both at the Health Optimization Summit. Are there any biohacking protocols per se that you adopt yourself? I know you're based at Human. So
yeah,
just wondering if there's anything that you...
Well, the things that I've used, which again have got a reasonable body of evidence and don't do harm, are things like hyperbaric oxygen, which is good for recovery. I've suffered from anxiety and depression after my dad died. I'm vaccine injured. So I think these things I've tried to use to help me as well. So hyperbaric is, I think, one of them. I've tried cryotherapy. During the summer, I was doing there almost every day. Although I got told by one of the scientists at Health Optimization Summit is best not to do it every day and more to do it on recovery days. But yesterday I went in for 5 minutes, I think minus 87 degrees centigrade.
Wow.
And just my shorts and whatever else. I've got a high threshold. I can stand that, and it's kind of fun.
That's insane.
So I felt better. I think I definitely feel better from cryotherapy as well.
Got it.
And red light therapy I've used. And red light therapy I've noticed a benefit with some, I'm very active in the sense that, within reason, I mix my cardio and resistance training, and have been, and the reason I talk about overtraining is because I've done it myself so many times, got injuries, because you get almost that obsessive trait.
Absolutely,
and even if you're not fully recovered and then you exercise and you get an injury, and as you get older, I'm 48 now, I'm more likely to get injuries. So I found the red light therapy helped with tendonitis, for example, or bursitis I had in my left shoulder, and there doesn't seem to be any downside.
Fantastic. Just to tie this up, what are 3 actionable tips that you would provide to people that want to optimize their heart health and delay the onset of heart disease for as long as possible? I
think diet is going to be primary, and I would say minimize the starch and sugars and go more Mediterranean with your diet. I would say, don't be sedentary. I think just if you can get out for a walk, at least 30 minutes a day, you don't have to keep it simple at the very minimum. And I think really focusing on thinking about what's causing your stress and what you can do to protect yourself and make you more resilient to stress. And that means better in-person social interaction. I actually prescribe hugging to my patients. I actually prescribe, to some of the cardio patients, I say do 20-second hugs, 8 to 10 times a day. I think these sorts of things, and minimizing social media, getting screen time, absolutely. No screens, 3 hours before bed, ideally, if you can. So these work on everything you can do to optimize your stress and sleep while simultaneously making sure your diet is good. If you do those 3 things, it's not necessarily easy, but that's the information we have, then you're going to be in a much better place.
Got it. Was just reminded of another point, seed oils, and there's a lot on social media around seed oils. Do you think they're a contributing factor?
I think that when they're heated, it's very good evidence that they're pro-inflammatory and they're toxic. When they're not heated, it's less so. One of the reasons seed oils have been pushed, other than being a cheap, form of preservative, if you like, is that seed oils lower cholesterol.
Right.
But they're pro-inflammatory. So I think they're harmful. Yeah, I think they're harmful. I avoid them, but more when they're heated. So you wouldn't fry in them, for example.
Fantastic. Finally, if there was a question you could ask the next guest, what would you ask them as it relates to peak human performance, health optimization, longevity? If you can ask them anything you wanted to ask them, what would you ask them?
What's their greatest source of anxiety?
Fantastic. Really appreciate your time, Dr. Aseem. Thank you for coming here with me today. Thanks.
Appreciate it. Cheers.